We are going to get started right now. So with that, I'm going to run through some of our introduction slides. Thank you again for joining us today. Today is another edition of our SPA State Plan Amendment Service by Service Overview Series for New York State's Children's System. Today we're going to be reviewing slides around the psychosocial rehabilitation services, and we'll be joined by some of our state colleagues. The content today is going to be presented by Maria Morris-Groves from the New York State Office of Alcoholism and Substance Abuse Services, as well as Allison Behan from Child Welfare and Community Services at the New York State Office of Children and Family Services. Some housekeeping and logistics for the webinar today. We are recording this webinar. It will be posted along with the slides that actually have already been posted to the mictac.org website. Usually the recording takes about a week to be available, so we would encourage you to check back in a week if you'd like to listen again to the recording from today. We also want to alert everyone about the WebEx chat functionality for question and answer. If you look to the side of your screen, there is the capability of chatting in questions. We ask that you select, when it says send to, that you select all panelists so that all the panelists and presenters today can see your questions. Questions not addressed today are going to be reviewed and incorporated into future training and resources. And just as a reminder, information and timelines are current as of today, which is July 7th, 2016. Content presented is a summary and discussion of the draft of the SPA manual, currently available online. You can find it on the MCTAC website. Please refer to the manual for further detail, definitions, references, and other useful information. So just reviewing some of the goals for today. Our goals are really to review the key information from the SPA manual, to add context and clarity wherever possible around the different details for the service, to generate and answer questions. So again, another plug to encourage our participants who are on this webinar to chat in questions frequently and often throughout the webinar, as we will be attempting to answer them at the end, determining based on how much time we have left. And also the goal for today is really to help inform service providers' decision-making process about obtaining SPA designation. The designation process is going to be finalized and announced soon, and as soon as that happens, a presentation and an opportunity for designation-specific questions will also be offered. So stay tuned to MCTAC to learn more about future training opportunities around SPA designation once that is finalized. So our agenda for today, our presenters, Maria and Allison, will take us through the Children's System Transformation and SPA Refresher and Update. They will then walk through psychosocial rehabilitation. There will also be a review of upcoming training and available resources, and as always, our grand finale is the question and answer session at the end. So with that, I am going to welcome and introduce our two presenters, Maria and Allison. Maria and Allison, would you like to get started?
Yes, good afternoon, everybody. As we begin, we're just going to walk through a little bit of some key dates and a little bit of a refresher about the Children's SPA. So if we look at the first slide, and what's ahead for New York State's Children's System, a couple of key dates for people to keep in mind and remember is on October 1st, 2016, we begin the implementation of Children's Health Home. The new state plan services, of which psychosocial rehab is one, will go into effect statewide on January 1st, 2017. The behavioral health and SPA services transition to managed care, including children in voluntary foster care, will begin on July 1st, 2017 for New York City, Westchester, and Long Island, and the rest of the state will transition on January 1st, 2018. Children's home and community-based services will transition to managed care at the same time as we move to behavioral health and SPA services. So if they are downstate in New York City, Long Island, or Westchester, they transition on July 1st, 2017. And if they're in the rest of state, it is July 1st, January 1st, 2018. So if we look at the Children's Medicaid State Plan Amendment and update, the SPA manual was released to the public for review and information on March 9th, 2016. As it's been pointed out previously, it's available on the MCTAC website as well as the Children's Managed Care web pages at OMH and DOH. The SPA includes 6 new state plan services that require CMS approval. Those services are crisis intervention, other licensed practitioner, community psych support and treatment, psychosocial rehabilitation, family peer support services, and youth peer support services. And today we're going to talk specifically about psychosocial rehabilitation. The SPA designation and application is in the final review stages and should be released shortly, and rates for these services will be released in the fall of 2016. So, as many of you know, the goals of Children's Redesign is really to identify and meet the children's needs early in their life, maintain a child at home with community support and services, prevent the need for long-term and/or more expensive services, and increase the delivery of services following trauma-informed care principles. All of this really is the reasons why the new state plan services are able to take effect. And as we move forward to the next slide, I'm going to tell you a little bit about how the manual is currently organized. So if you've looked at the SPA manual, you'll see that we define the service component. We talk about the allowable service modality, the settings by which the service can be delivered. It talks about admissions, continued stay, and discharge criteria. Important to note there is in that is built-in medical necessity criteria that will be used for both admissions and utilization management of the service, limitations and exclusions, agency supervisor practitioner qualifications, training requirements and recommendations, and recommended staffing ratio and caseload size. And again, if you're interested in reviewing the manual and have not seen it, it is available on the MCTAC website. So some key points. We talked earlier about the vision of being able to intervene earlier in a child's life. Because of that, the proposed Medicaid state plan services will be available to children under the age of 21 who meet the medical necessity criteria. So again, the state plan services that we're talking about today and all of the webinar series, this part of the webinar series, will be available to all children under the age of 21 who are on Medicaid who meet the medical necessity criteria for that service. It will be delivered in a culturally competent manner and be trauma-informed. It allows for interventions to be delivered in natural community-based settings where children and their families live, and bolster lower intensity services to prevent the need for more restrictive settings and higher intensities. These services all fall under early periodic screening, diagnostic, and treatment, formerly known or currently known as EPSDT. Additionally, the new benefits are standalone services. They're not programs for SPA-designated providers. They are services that providers can apply to deliver. Services provided to children and youth must include communication and coordination with the family, the caregiver, and/or legal guardian. Coordination with other child-serving systems should occur to achieve the treatment goals. When the children's SPA services launch, they'll initially be billed under Medicaid fee-for-service until they're transitioned to Medicaid managed care. Once designated for SPA services, providers can begin to bill their contract negotiations with managed care plans in January of 2017. I think the important piece to know in all of this and to remember is this suits our vision of intervening early in a child's life. The EPSDT array of services for children under 21 is what allows us to really look at this from a primary intervention early and prevention of further issues down the road. So if we look at a little bit about medical necessity criteria on the next slide. Oh, there we go. Medical necessity includes any treatment that correlates or emulates chronic conditions found through an EPSDT screening or addresses the prevention, diagnosis, and treatment of health impairments, the ability to achieve age-appropriate growth and development, and the ability to attain, maintain, or regain functional capacity. Each state plan services will have criteria for admission, continued stay, and discharge. I think the important piece here is that we want to intervene early and restore functioning, and that we are going to be looking closely at admissions, continued stay, and discharge for each of these services. And further medical necessity language will be coming shortly. So now Allison is going to talk a little bit about the service itself.
Hi folks, this is Allison Behan from Office of Children and Family Services. I'm going to talk about the service of, as we talked about, psychosocial rehab, or we like to call it PSR. So if we go to the next slide, we'll talk about what that really looks like. Psychosocial rehabilitation are interventions to compensate for or eliminate functional deficits and interpersonal and or environmental barriers associated with a child's youth behavioral health needs. The service is for children and their families, and the key point, the intent on slide 13, is to restore, rehabilitate, and support a child-youth functional level as much as possible and as necessary for the integration of the child-youth as an active and productive member of their community and family with minimal ongoing professional interventions. We define family on the next slide, and we're really excited to see that we think of family as a unit of people that are residing together with significant attachment to the individual. This includes both adults and children, with adults taking on parenthood, caregiving for the children, even if the individual is living outside of the home. The family, in our definition of this service, is inclusive of the whole wide range diversity of primary caregiving units that may include the following types of relationships. And it's a birth family, a foster family, an adoptive family, or a self-created unit of a family. On the next slide, we talk about our service components for psychosocial rehab. This is key because when thinking about this service, the activities must be task-oriented and intended to achieve the identified goals or objectives as set forth in the treatment plan. And the next slides will go through what these components really look like, but we've bulleted them out on this slide so you can really see how the service options within psychosocial rehabilitation fall into these categories. We talk about personal and community competence, social and interpersonal skills, daily living skills, personal autonomy and health skills, social skills, as well as community integration. So what do we mean by all of those? On slide 19, personal and community competence. So it's using rehabilitation interventions and individualized collaborative hands-on training to build developmentally appropriate skills. So what's the intent? The intent is to promote personal independence, autonomy, and mutual supports, to develop, strengthen the individual child's independent community living skills. And lastly, support community integration in the domains of employment, housing, education, in both personal and community life. On the next slide, you'll see we think about social and interpersonal skills related to the service for psychosocial rehabilitation to restore, rehabilitate, and support. And this is a nice long list, and it really is thoughtful, beginning with increasing community tenure and avoiding more restrictive placements, enhancing personal relationships, establishing support networks, increasing the child's community awareness, develop coping strategies, and effective functioning in the individual's social environment, including their home, work, and school. Learning to manage stress, unexpected daily events and disruptions, and symptoms with confidence. developing interpersonal skills when interacting with peers and maintaining friendships or a supportive social network while engaged in a recovery plan. Training on social etiquette, as well as developing self-regulation skills, which includes anger management. On the next slide, on slide 21, you'll see we think about daily living skills. And when we think of restoring, rehabilitating, and supporting daily living skills, it falls into the three categories of 1, improving self-management of the negative effects of psychiatric, emotional, physical health, developmental, or substance use symptoms that interfere with a person's daily living. Support the individual with development and implementation of daily living skills and daily routines that are necessary to remain in the home, school, work, and their communities, and wellness skills. And that includes things like meal planning, healthy shopping and meal preparation, nutrition awareness, and exercise options. Slide 22 breaks down personal autonomy and health skills. We put them side by side. The personal autonomy skill set that we talk about is helping children learning about self-care, developing skills that are specific to managing medications, and self-care that are consistent with the directions of the prescribers. This also includes developing methods of communication with prescribers about medication side effects or issues, and lastly, gaining the ability to make independent choices and take a proactive role in their treatment, including talking with the treatment provider regarding questions or concerns. Under the health skills category, we think of developing constructive and comfortable interactions with healthcare professionals, relapse prevention, planning strategies, managing symptoms and medications, as well as reestablishing good health routines and practices. On slide 23, we think of personal autonomy and health skills, and so we thought of some examples we could throw out to you folks to start thinking about. So this is developing daily living skills, as we talked about, specific to managing medications and learning self-care consistent with the direction of prescribers. So what would that look like? The example is setting an alarm to remind a child when it is time to take a medication, and developing reminders through a calendar when it is time to refill a prescription. The other topic we talk about is developing methods of communication with prescribers about medication side effects or medication issues. So this is helping the youth to prepare for an upcoming appointment by encouraging them to write down their questions and concerns and bring them when they meet with their prescribing physician. So those are some examples. On 24, we talk about social skills, and what we mean by that is implementing learned skills so the child can remain in a natural community location and achieve developmentally appropriate functioning. Reestablishing social skills includes developing conversation skills and a positive sense of self to result in more positive peer interactions. Coaching on interpersonal skills and communication, transportation, navigation, developing and pursuing leisure and recreational interests, the use of community resources, money management, as well as trigger avoidance. And what we mean by that is helping the individual with effectively responding to or avoiding identified precursors or triggers that result in functional impairments. On slide 25, we talk about community integration, and that relates to the restoration, rehabilitation, and support of the identification and pursuit of personal interests that support community integration. That's a lot of words, but when we distill it down to identifying resources where interests can be enhanced and shared with others in the community, and identifying and connecting to supports and resources, including family, community networks, and faith-based communities. And so some examples, as we have on the slide, are creative arts and reading and exercise. You see the examples here. So that's when we think of a community. We have such diversity across New York State, that's what we mean. So by example, we're going to talk about Susie. Susie is a young lady, she's 17, and she's struggling quite a bit with obesity, and this is due to her depression. She is a young woman, I should say, that attends outpatient therapy, and she has worked hard to develop a treatment plan with her licensed practitioner. One of the goals that was developed through this work for Susie was about acquiring healthy wellness skills. So the PSR, or psychosocial rehab provider, has a collateral contact with a licensed practitioner. They have a discussion and focuses on the tasks on assisting Susie with meeting this goal in the community. And again, the goal of acquiring healthy wellness skills. So the PSR provider reestablishes Susie's nutritional awareness and formulating a menu plan. Once a week, the PSR provider takes Susie to the grocery store and supports her choice of healthier food options when she's shopping. A different example is about a younger child, and his name is, we call him David, and he's 10, and he's very interested in playing soccer. But he has difficulties in socializing with other children because of his anxiety. So the child's clinician, so David's clinician, recommends PSR for him and develops the treatment plan with the intended goal of David acquiring healthy social skills with others during practice for soccer. And the PSR provider can assist David in restoring his self-regulation techniques to prevent inappropriate outbursts during his soccer practice. So there's real potential here for the PSR clinician to work with David to achieve his goals. The allowable modalities, as even by example, you see that the interventions must be face-to-face. They can include collateral contacts as long as the contact is directly related to the recipient's goals and treatment plan. So the options for this service for psychosocial rehab is individual work, or there is an option for group work. And we say groups, they should not exceed 6 to 8 members, excuse me, with certainly consideration of smaller groups if the participants are younger than the 8 years of age. In these groups, the membership of the group should really share common characteristics such as related experience, developmental age, chronological age, challenges, or treatment goals. And those are the modalities that we expect this service to be delivered in.
So now we're going to talk a little bit about the settings and the caseload size for this service. The settings, PSR can occur in a wide variety of settings, including community locations where the child youth lives, works, attends school, engages in services, i.e. a provider office site, and or socializes. So, if you're working on skill building for that young man that's learning how to self-regulate and play soccer, the PSR may actually occur in conjunction with him attending soccer practice. So the PSR is going to do some work with him, and then he's going to go off and try those skills. The caseload size, based on the needs of the child and the youth and families with an emphasis on successful outcomes. Individual satisfactions and meeting the needs of the identified in the individual treatment plan. So the caseload size is going to vary a little bit depending on the needs and the size and scope of the kids and families that you're serving. Provider agency qualifications. Any child-serving agency or agency with children's behavioral health and health experience that is a licensed, approved, certified, or designated by the Department of Health, the Office of Alcoholism and Substance Abuse Services, the Office of Children and Family Services, or the Office of Mental Health to provide comparable or appropriate services referenced in the definition. So if you are in any one of those types of agencies, this service might be a service that you might want to look into delivering. They must comply with the following requirements: adhere to Medicaid requirements, ensure staff receive training on mandated reporting, practitioners may obtain licensure necessary to provide services, maintain needed insurance, follow safety precautions needed to protect the child population, adhere to cultural competency guidelines, and be knowledgeable about trauma-informed care. Individual staff qualifications. Staff must be at least 18 years of age, have a high school diploma or high school equivalency is preferred, or a state education commencement credential. Have a minimum of 3 years experience in children's mental health, addiction, or foster care. The practice of PSR by unlicensed individuals does not include those activities that are restricted under Title VIII. So who can supervise this service? PSR providers must receive regular supervision from a licensed clinical social worker, a licensed mental health counselor, a licensed creative art therapist, a licensed marriage and family therapist, a physician, a psychiatrist, a physician's assistant, a registered nurse, or a nurse practitioner. So while the person delivering the service may be uncredentialed, they need to be supervised by what we've called, and you've heard us talk about before, a licensed practitioner of the healing arts. Supervisors must be also aware of sensitive to trauma-informed care, cultural needs, and how to best meet those needs, and be capable of training staff regarding those issues. So training requirements and recommendations. Individuals delivering PSR must have training in engagement and follow-through, group facilitation, identification and delivery of functional skill building, interventions, personal health, including medication advocacy and coaching, autonomy and community competence. Recommended training would include training on domestic violence, motivational interviewing, personal safety in the community. And we're going to talk a little bit about admissions and continue to stay. The child or youth has a diagnosable behavioral health condition as classified in DSM-5, including V codes, and the service is recommended by any one of the following licensed practitioners of the healing arts operating within the scope of their practice under state license. And there are many of the folks that we referenced earlier on in the previous slide. So we continue. The service is included in the Child and Youth Treatment Plan. A licensed community psychiatric supports and treatment practitioner or other licensed practitioner must develop the treatment plan with the PSR worker implementing the interventions. Outlined in the treatment plan, including developing skills or achieving specific outcomes. The frequency and intensity of the service aligns with the unique needs of the child. So treatment plan and notes. The treatment plan must specify the amount, duration, and scope of service and should be developed or revised in a person-centered manner with the participant of the child, youth, family, and providers, reevaluated to determine whether services have contributed to meeting the stated goals, and revised with different strategy goals and services if there's no measurable reduction of disability or restoration of functioning level. Discharge criteria. The child or youth has successfully reached individually established treatment plan goals for discharge. The child and youth and family have been involved in the discharge process. So some remaining things to be announced. The provider designation criteria and process, the PSR billing methodology and coding structure, the PSR medical necessity criteria, and any additional PSR limitations, SPA services and documentation requirements, and utilization management process. Once these are finalized, they'll be incorporated in the SPA manual and shared very widely with everybody. So we've ended the section where we're talking about psychosocial rehabilitation, or PSR. If you haven't already typed in your questions, that would be a good time to begin to do so. But before we turn it back over to MCTAC for the question and answer period, a reminder of some training and resources coming up. This is the second in the SPA training series. Last week we did one on other licensed practitioners that should be posted to the MCTAC website. Next week on July 14th, there'll be one on family peer support services and youth peer support and training. On July 21st, community psychiatric supports and treatment, and on July 28th, crisis intervention. For those of you that are looking for CANS training or training on the child and adolescent needs and strength instrument, there was training in Albany on June 22nd and 23rd. In New York City, there'll be training July 12th and 13th, and again on August 29th and 30th. In Rochester on August 18th and 19th. And also a reminder that the training is available online for those folks who would like to access it that way. And if we go to the additional spot training plan, so here is kind of what our rollout looks like for the rest of the year. June and July, high-level service-by-service overview, the designation process, billing rules when they're available. So this webinar series that we're doing now. In September, we're going to spend a lot of time with you on rates, billing codes, staffing requirements, caseloads, eligibility, EHR. Hopefully, some of this will be delivered in person. In October, referral process, documentation, continuing education, co-enrollment, exclusions, health home interaction, and reporting requirements. November, December, detailed training for each service, full day statewide in person with some web-based supported supplements. And in January 1st, 2017, we will go live and provide ongoing training on the state plan services. So again, if you have not already done so, now would be a great time to type in your questions. And as we turn it over to MCTAC, we would remind you of the different email places that you have the ability to get your questions answered. As always, when you're emailing OMH's Managed Care or OASIS's Pick'em mailbox, it is helpful if you write in the subject line, please specify kids systems or children's systems management. So we will turn it over to MCTAC to take a look at some of the questions.
All right. Thank you, Maria and Allison, for leading us through the content of those slides. So we are going to take just about 15 to 20 seconds to review all the questions that have come in. I want to encourage, as Maria and Allison so graciously did, if there's any more questions, we would encourage you to chat them in now. And if you give us a couple seconds, we'll be back. We're going to make sure our state partners all have the questions in front of them before we try and answer them. Okay, so this is Meg. I'm back. I'm going to see if Maria and Allison, in looking through the SPA questions that are on our shared document, are there any you would like to start off with?
We'll be right with you. We've just
perfect.
Coordinating our answers.
Absolutely.
Yep.
Sounds great.
And while our presenters are sorting through the questions, I did want to just thank everyone who continues to chat in their questions. We appreciate that. If there are any questions that come up after this webinar is over, I do want to encourage everyone to send any questions either to the emails listed on this slide, our state partner emails, or even the mctac.info@nyu.edu. If we are unable to answer a question, we always pass it along to our state partners for assistance. So just to be sure that if you do have any outstanding questions, you can always, even after the webinar, send us a quick email and we'll do our best to get you an answer.
Okay, I'm going to take it. This is Maria. We're going to take a stab at answering a couple of them. And then if our other state agency partners see some that they would like to answer, please feel free to chime in. We're going to start with the first one, are SPA services being offered prior to the implementation of managed care? Yes. On page 8 or slide 8, we talk about the roll-in dates for the different state plan and managed care things. So, you know, health homes in October of this year, the new state plan services will be available January 1st, 2017 on a fee-for-service basis, and then we'll roll into managed care in July 2017, and for the rest of the state in January 2018. The home and community-based waiver services, again, will follow with the upstate, downstate split. There was a couple of different questions around family, and Allison's going to so graciously let me answer that and remind folks that they can refer to the very broad definition of family that is on page 17 or slide 17. So a family unit is a group of people residing together with significant attachment to the individual that includes both adults and children, and is inclusive of a wide diversity of primary caregiving units. So we would again ask you to refer to that definition in the slide and in the presentation. If you have further clarifications, you could certainly email any one of the email boxes and we would certainly provide you with a further definition of that. When we scroll down the list of questions, some folks had some questions about how do SPA services interface with Children's Health Home. I'm going to take a stab, but then if my health home colleagues at the Department of Health have a further clarification, they can feel free to answer. The health home is a care management component, and the SPA services are services that the health homes will have available to them to make referrals to. Is there anyone at DOH that would like to provide any further clarification?
This is Anna Dean from the Department of Health.
Okay, great. Thank you.
Thank you, Maria.
This is Allison Bean from OCFS. Someone had asked, will Children's Health Home be considered a PSR service? And as Maria just said, I just want to echo that Children's Health Home is care management. And as she talked about, it begins in October of 2016 of this year. And PSR, or Psychosocial Rehabilitation, is actually a state plan service. And as we've talked about at length, is very much a skill-driven service with practitioner quals, including who can supervise these individuals. So they're two very different things. Although, as Maria said a minute ago, the Children's Health Home folks, those care managers, can refer to the service of psychosocial rehab, or PSR.
Here's another question that I think is a good one to clarify for everyone. Are SPA services available only to children who are enrolled in health home, or can any child who meets the medical necessity criteria be referred by a licensed professional? I think the beauty of the 6 new state plan services that we're going over with you over the next couple of weeks is that these services are meant to be available to all children on Medicaid who meet the medical necessity criteria for those services. So for example, if you refer to slide 12, the first bullet says, the proposed Medicaid State Plan services will be available to all Medicaid eligible children under the age of 21 who meet medical necessity criteria. So that means that children who may not meet the qualifications for health homes would be eligible for the state plan services, assuming that they meet the medical necessity criteria and they are referred by a licensed practitioner of the healing arts, which can include their primary care physician or their pediatrician. Here's a question that I think is a really good one, and I'm happy to see it be asked because oftentimes we don't get to the substance use disorder services. Someone asked, could you give a couple of examples about how SPA services might work in conjunction with substance use disorder services? So if you look at some of the definitions that we've provided about restoring functioning, establishing connection to community supports, one of the things that might happen on a short-term duration is really helping that youth establish some positive social and emotional supports. So perhaps using a recovery coach or a certified peer recovery advocate youth to help them develop positive social interactions in the community where they might not necessarily have had them previously. That person may also help them learn to navigate the CD, the chemical dependency system, or the addiction treatment system, and be able to ask questions perhaps about medication-assisted treatment or other types of services that could be available to them. So I think this is a natural place where you may see some referrals being made out of the addiction service system to help the youth with a substance use disorder really establish some positive health, wellness, and recovery goals. Good one. How does pediatricians learn about SPA services? I think one of the things that we are all committed to doing, and will definitely be doing much more of as we move forward, is looking at a way of marketing these state plan services to the pediatric community and the physicians community. And we would also look to the providers who are going to be designated to provide these services to work within their communities to show where they're designated. And we will also do quite a bit of work with the managed care plans to understand the services and also to make them available and knowledgeable of their provider networks that includes physicians and other healthcare practitioners. Will there be a master list of providers of SPA services online to make it easier to access services?
Yeah, so this is Allison B, and I certainly know that if you've heard three voices today, you've heard the Department of Health, you've heard OASAS, you've heard OCFS, and I know our friends at OMH are on the phone. This is a real collaborative nature of this work, and we all have different agency websites, and we are working very hard to see how we can make sure that the information is posted clearly, as we talked about in the presentation. The criteria is still being defined, but absolutely it is our goal to make this information public, utilize electronic resources when possible as things become, as the year goes on and these trainings are completed and providers are applying to become designated for SPA services, so that it's accessible to not only the children and families that we could potentially be serving, but also to the community practitioners. Somebody just asked about pediatricians, schools. We do want to make this information public, and we'll work very hard to get that information out there. So our folks, friends from the Office of Mental Health or the Department of Health, you're seeing the questions. Would you like to jump in at any point and answer any that you're seeing that are maybe more respective to your populations?
This is Anna Dean from the Department of Health. I am seeing the questions that have come through, and it looks like most of them are that were specifically related to our population or anything related to health homes. Our partners have, thank you very much, have answered those questions very well. And if there are any other questions related to the health home services or any DOH populations in specific, feel free to bring them through.
So as Allison and I look through the list of questions, I know we haven't necessarily hit on all of them. Some of that is because we want to take them back to the state agency partner table and make sure that we've given you the most accurate and up-to-date information. So at this time, unless other people are typing in some additional questions that we may not have seen, Megan and Caitlin, we are going to turn it back over to you and thank everybody for taking some time with us this afternoon to learn about psychosocial rehabilitation and to remind them of next week's webinar on youth and family peer support services.
Thank you, Maria. Thank you, Allison, and thank you, Anna, for answering questions, presenting. We really appreciate it. Just a reminder, we are going to post this recording of the webinar on the MCTAC website shortly. The slides from today are already up there. And for future webinars, to sign up and register, we would also encourage you to visit the MCTAC website so you can join in on the rest of this series. And additionally, if you do have any outstanding questions, please feel free to either email them into MCTAC or any of our state partner email inboxes that are listed on the slide in the presentation. Just be sure to put in the subject that this question is targeted towards the children's system and managed care specific. So with that, I want to thank everyone for joining us today. Again, thank you to our state partner presenters, and I hope you join us again next week for the next webinar in our State Plan Amendment series. Hope everyone has a good day. Take care.